Hi everyone, welcome to another VMR. Today I'm very happy to say that I'm going to discuss with Rabih. It's always I'm always very excited to discuss because I learned so much. So if anyone has a case, please, we would love to discuss your case.
Always a treat, Marcelo. We all should give you a big high five for being done with your interviews and ready to transition to the anxious wait for the match. So congratulations. We're really, really happy for you.
Oh,
And
thank you so much, Rabih.
we know it's going to be absolutely amazing. Yeah,
Oh,
we got 30 minutes to rock and roll today. So anybody have a case that they want to present to Marcella and I?
I would say that I love ID, but it doesn't have to be ID.
Yeah.
It can be anything, guys.
Have you guys realized that the suspense that Deborah is pointing out is so weighty and so strong, but it's only like 3 seconds. It's incredible
Yes.
like how quickly and how powerful. Like people do not tolerate silence, which I think is like a part of our like 21st century busy like always go life. Like your mind is so used to like stimulation. If it's not stimulated, there's something wrong. So I'm working on living in the suspense, as Deborah would like to say. We should someday.
Yeah. Yeah, maybe I think being silent would be more difficult than just discussing, It like you said, it's so hard. I have been doing some yoga and it's so hard when we have to stay in silence and meditate. So it's something that we need to get used to, and every minute counts, and it's great. It's good for anxiety.
I completely agree. I think yeah, I think we should do a VMR session where we just tell people we have the best case ever and get all the people to join and then just sit there for an hour. That's complete utter silence. This is also a great test of who can tolerate the silence the least well. Like you know. Nada. Okay. Okay, there we go. Hans is our most go-getter person. Hans,
Thank you, everyone.
thank you. You're the best. We really appreciate you. Just in case there's maybe one or two people who haven't met you, Hans, do you want to reintroduce yourself and then we'll jump right in?
Yes, I'm a graduate from Ross University and presently basically observer, volunteer in Canada and in Germany as well, and hopefully I'll match somewhere. Just the same suspense. So I do have a case. I mean, if somebody else has a case, I would definitely say somebody else go ahead, but otherwise it fits 30 minutes.
Perfect. I have an ulterior motive, which is I always learn so much when you present, Hans. So I will take advantage of the fact that you are jumping in today. And yeah, let's do it.
Okay, that's the chief complaint looks like bread and butter. So we have a 16-year-old African Canadian American female who presents with abdominal pain, at times very severe and even cramps, and it's been going on for 7 days.
Okay, thank you so much, Hans. And I would like to say first that your cases are never bread and butter. We always learn so much, and it's such a big challenge, like Rabih says. So I'm very excited to discuss your case. So first, I can see that we have abdominal pain, and something that I learned from Rabih is that usually when we have abdominal pain, we need an imaging because we have so many different causes for abdominal pain, and it can present in so many different ways. For example, if the patient has diabetes or something different, could be like even heart attack or something related to that. So, oh, it's 16-year-old. Okay, so she is a young patient, and she's having this abdominal pain for 7 days, which make me worry that something not so acute, but subacute. So I'm thinking more like an inflammatory cause more than, for example, vascular causes that present even more acute, or perforation. So I'm thinking more in the bucket of inflammation now. So I'd love to know if she has any other signs of inflammation. And I can see that's very severe. So it's like an alarm sign for me, which makes me want even more to order an imaging. And something that, like, you mentioned that she's African American. If it was like a step one question, we would always think about like genetic causes, like sickle cell disease or things like that. But I think that we need to rethink our bias, because I think that sometimes like step one and all those questions just frames some bias in our minds. And I think for clinical reasoning, it can be bad in some way, you know? So I'd love to know your thinking, Rabih.
My favorite part of that conversation was your poetic response to all the complex dimensions of this case, and how passionately Yasmin was head nodding in support for your, I'm not sure if you saw that, but she literally was like, yes. I agree with everything that you're saying. And I think it's amazing how when you have a patient of childbearing age, how that word influences the calculus. Knowing if she's pregnant or not will influence tremendously what you think is the cause and how you work it up, including what imaging you get, because imaging with CT scan is much harder in patients who are pregnant or much more complicated, as is the treatment that you give the patient. All of a sudden, the pharmacological therapy that you give will have to be factored in as you're giving it to a fetus too. So the DX is complicated, both in terms of what is possible and how you get to the bottom of it. And your RX is very, very different. So I think the first question is, what is her urine pregnancy test? The thing to invest diagnostically is to completely emphasize what you just said about the role of imaging in abdominal pain. What's curious about this specific narrative is the fact that it's occurring in cramps. And now, what does that mean? You have to study that space a little bit more. But what would be interesting is to wonder why her pain gets better. So pay attention to that. Cramping means it comes and goes. Now, why would pathology have such a biphasic manifestation? That biphasic manifestation is likely a clue to the nature of the cause. For example, pancreatitis doesn't present as cramping. There's no reason for the pain to ever get better, for the cramp to ever be relieved. So I think that's a good exercise for us to layer on at the end to say, was the cramping actually explained, and was that a clue in retrospect? I suspect it will be. All right, Hans, tell us more.
Okay, the HBI. The patient moved 10 years ago with her parents to Canada from Africa. She presents with abdominal pain for 7 days, I just mentioned. She denies any past medical history. The patient also denies use of drugs, alcohol, or recent travels. The pain comes and goes, as she mentioned in the chief complaint. And at one time it was so bad that she had to leave the classroom and go home. And that's basically the HPI. And next would be aliquot 2 for past medical history meds, if you like. We can do that as well.
Yeah, let's do it, Hans, since we're in the 30-minute format. Let's do it.
Mm-hmm. So no past medical history as mentioned above, and no medications. Family history is unremarkable, and she's a high school student who lives at home. She denies alcohol, recreational drugs, and tobacco. Shall I continue with the physical exam just to get some clues? Okay, just the physical exams. We have a normal temperature, which was 36.3, heart rate 82 per minute, blood pressure 120/70, respiration 15, and SO2 said 99% room air. General, patient was deeply concerned about her condition, but not in pain. So during the exam, she was fairly relaxed. HENT within normal limits, heart and lung is unremarkable. And the abdominal exams. The bowel sounds are present, percussion, some ascites was found or noticed upon palpation. Percussion, sorry. Upon palpation, we have tenderness throughout the abdominal region. So not severe pain, but tenderness all over the place. That concludes this report. Next, other labs.
Okay, so right now I'm thinking that for her vital signs, she seems to be stable, so it's good that we have some time to think. And the first thing that I noticed here is that I would like to go back to the history if possible and try to get more details, in the sense that, like Rabih mentioned, the pain seems to be very intermittent. So I'd like to know if there is a relation with, for example, eating, if it's after she eats, or relation with bowel movements, and how are her bowel movements. And then the other thing that I'm noticing that can kind of narrow our reasoning, I think, is the ascites. So probably we need to tap that and see which type of ascites, because we need to see if, for example, she has something, for example, portal hypertension, or if it's something on her, for example, peritoneal disease that is causing the ascites. So I think that's going to be key for our reasoning moving on.
I love that. I think you're identifying the key feature, Marcella, and you're saying, is it portal hypertension, i.e. transited, or is it a peritoneal disease? And what that fundamentally means is it some form of peritonitis? So is it transudative portal hypertension or exudative peritoneal? And if you had to make an educated guess, a working hypothesis based on your data now, where are you inclined to go?
I think I'd say that maybe for her age and her, like, she moved from Africa, I'm thinking maybe, and I like ID, so yeah, I think the exposure history, so maybe she was exposed to TB or something like that. Although she doesn't have any risk factor, her age and nutrition status can be something that can be related to that. Or even we know that if she was exposed to schistosomosis, that's something that can happen and cause abdominal pain and explain the ascites in a 16-year-old. Because I'm not thinking so much about cancer or some, of course it can happen, but it's not the age that we first think about that.
I completely agree. I think it's actually pretty hard to decide. So for portal hypertension, the vast majority of patients with portal hypertension have cirrhosis, 90%. And so the lack of signs of cirrhosis here makes it much less likely, but you're saying there are non-cirrhotic causes of portal hypertension, including schistosomiasis. The thing that makes them a little bit less likely is the fact that there's no signs of superficial portal hypertension, caput medusae, for example, or lower extremity edema. But I agree. I think from the portal hypertension category, we can say cirrhosis is unlikely and non-cirrhotic portal hypertension is still fair game, but made less likely by the lack of other signs of portal hypertension like caput medusae. You're pointing out the big tension in the lack of peritoneal disease, because most peritoneal disease that lasts more than an hour is usually hematogenous dissemination to the peritoneum. So that is a complicated sentence. I'm going to repeat it one more time. Most peritoneal disease that lasts for more than an hour is from hematogenous dissemination. That's because acute peritoneal disease is the result of GI perforation and perforation from the GI tract. Okay. Now, other peritoneal diseases are things like TB, malignancy, and rarely some autoimmune diseases. And those usually have a subacute time course much longer than a week. So the real question is, are there any causes of exudative peritonitis that are in this very interesting time zone between hyperacute and subacute. Because if Hans changed the story and said 3 months, I think you would think TB. Or if Hans changed the story and said 1 hour, you'd think, oh my gosh, did she have a perforation? But Hans is saying, as Hans always does, intriguingly, that she's had it for 7 days. And I think the answer will lie in saying what kinds of peritoneal diseases show up in an acute manner, not hyperacute and not subacute. And I will tell you, our dear friend Leah has already presented a case like this. Do you remember that case?
Yes, I remember. I was thinking about that
Yeah.
right now. The inflammatory pelvic disease, and it can
100%.
migrate to the peritoneal and cause like liver disease. Maybe that can explain the pain, and it could explain the ascites.
Exactly. So I think it would be premature to lock down our thinking, but I will just say this. The most powerful feature in this case is exactly what you said. It's the ascites. And the most curious clue about the ascites is the following. It's isolated, meaning that there's no other evidence of other diseases. And it is in a very intriguing window between 1 hour and 1 week. The time course here is a very, very powerful variable that deserves a lot of scrutiny, but hopefully scrutiny in the context of more information that Hans has for us.
Then I'll continue with the labs. And the first range of labs, CBC, everything within normal range. So WBC, HB, and platelets all normal. Chemistry, all within normal range, including the creatinine, calcium, and magnesium. Then a peripheral smear, normal, no atypical cells, so that was okay. Liver function tests, ALT, AST, and alpha fetoprotein, they were all normal. Amylase lipase normal. Then we have a CRP of 39, which is elevated. The normal range is indicated between 0 and 5 milligrams per liter. And ESR was 42, and the normal range is between 0 and 20. I could continue with imaging, if you like, to get a few more clues.
Go ahead, Hans. Yeah, that sounds great. Thank you.
Okay, so the imaging, first the routine, a chest X-ray is completely normal. There are no infiltrations and no effusions. And the interesting one is the ultrasound abdomen. So we have abdominal free liquid deposition with septations being seen in the fluid, multiple implants in peritoneal surfaces along diaphragmatic hepatic region and right paracolic area. The biggest implant was around 16 millimeters. Then an OB-GYN, pelvic US. We have endometrial thickness, which is normal, nothing unusual there. Left ovary septated cyst, 39 times 27 millimeter. And if you like, we could continue with a paracentesis of the cyst and the acidic fluid and then discuss. We need further labs. That's where the diagnosis is coming from. So paracentesis of the ovarian cyst, inflammatory cells, rich in lymphocytes, and most importantly, because we were thinking about a malignancy, but not in such a young patient, no malignant cells were found. Acidic fluid, so the SAG is less than 1.1, so it is exudative.
Okay, thank you so much, Hans. So right now we have more clues. So first we see that we have some inflammation. We could kind of see that from the exam, but the imaging, I think, helps us a lot. So I see that we have these implants, and right now I'm thinking because of the tempo of the disease, if maybe it could be an infection, like we were mentioning before, an inflammatory pelvic disease causing those implants of inflammation, or like people mentioned in the chat, endometriosis, if it could be already a disease that she had. So maybe go back to the history, check her gynecological history. That could help us with some clues. But also if she had like an ovary cyst or an endometrioma that ruptured, it could cause the bleeding and cause inflammation and then explain the ascites. So I'm thinking kind of in that sense. What do you think, Rabih?
I completely agree with you. I think, if you just step back and you think about this case, it's helpful to characterize exudative ascites as hematogenous dissemination to the peritoneum, or as a reflection of local disease. So the big schema, and by the way, this schema is on RLR-CP solvers. I was trying to find it now, but it was too hard to find. So yeah, it's like peritonitis is either disseminated TB, disseminated cancer, or local. And local diseases that cause peritonitis are GI diseases, GU diseases, and GYN diseases. The best example of a GI disease is perforation, but you can have it from eosinophilic ascites and all sorts of things. And GU disease is rupture of the bladder. That can do it. Gynecological diseases, many, and it's best understood by studying the gynecological disease. And here we have a 3.9 centimeter ovarian cyst. Now you have to be careful, because the ovary, the way we can connect the dots most commonly is to think that the ovarian process has gone to the peritoneum. That's the most common. But the knowledge of the entity of Krukenberg disease or Krukenberg tumors is a reminder that diseases can disseminate to the ovary and to the peritoneum simultaneously. So if you're trying to connect the dots, it's easy to go ovary, peritoneum, but there may be something underneath that is going to ovary and to peritoneum. And that's possible. That hypothesis is reduced in probability by the acuity of the disease. Because if something is going so many places, it usually doesn't do so over 7 days. But remember, the time course that the patient is reporting may not be the time course of pathophysiology. So if we make that assumption, we say, hey, the ovarian process is likely gone to the peritoneum, recognizing that assumption is an assumption. And then I think the real DDX is, what is the cause of this ovarian cyst? And it could be a simple cyst that bled, for sure. It could be a malignant cyst with dissemination, or this could be a perineoplastic phenomenon. And the perineoplastic phenomenon is termed Meigs syndrome, MEIGS, where a benign ovarian tumor, like a fibroma, causes ascites. And it does so through mechanisms that we don't fully understand. So I think the real question is, what is this ovarian cyst? And if we apply the knowledge that Hans gave us from the paracentesis did not appear to be hemorrhagic. So a simple cyst rupturing makes that a little bit less likely. Both the age of the patient and the lack of cytology are independently not sufficient to exclude cancer, but reduces the probability together of that being the finding. However, that's the thing that I think most people would be worried about. So I think in all, you factoring in the age and factoring in the lack of hemorrhage and the lack of cells, I think it's probably a good idea to lead with a benign tumor and a perineoplastic phenomenon. But in real life, the most daunting concern would be that of malignancy, which would be very, very unusual. And at the end of the day, the last hypothesis has to revisit the initial notion of, wait, maybe this is actually a disseminated disease to the ovary and to the peritoneum that would occur from tuberculosis. So I think you'd have to think about that too, but only after the more likely hypotheses. But tissue is the issue, I think. Now that you've had more time to think, Marcella, what other thoughts do you have, or how does that jibe with you?
Yeah, that was beautiful, Rabih. Thank you. I'm just reflecting in how much it's important to have this, like, when you have the experience to look at the clues that are going to be key for your clinical reasoning. And that's amazing. And I think we need the tissue to know better. And Yeah.
But I think this is a good time to emphasize what we were talking about earlier, hinting at earlier by referencing Leah's case. A ascites that is not hours and not weeks old, ascites that is days old, is usually gynecologic in origin. To make that point more clear, that hypothesis has now borne fruit. We were saying, hey, it's weird that it's this duration. We were hinting that it's gynecological by remembering PID, and I think that line of thinking has been productive. All right, Hans, tell us what you did next and what happened.
Okay, at first, malignancy was tried to be excluded, and there are further labs. And then I have an MRI abdomen as well. So AFP, as mentioned before, it was normal. Then a CEA, which was for colon cancer, which was normal. Then CA15-3, which is breast cancer, which was within normal range. Then CA19-9 for pancreatic cancer was 1.14 within normal range. And CA125, which is for ovarian carcinoma, was at 107.5. And the normal range is between 0 and 35 units per milliliter. So the next would be to just look more closely at the abdomen and pelvis. So CT thorax, abdomen showed bilateral lymphadenopathy with paratracheal subcarinal lymph nodes. Biggest was 20 × 13 millimeter. It's really a complex case. Lymph nodes, bilateral, anterior diaphragmatic, and right cardiophrenic. So we had lymph nodes seen. Abdomen, as mentioned before, we have fluid accumulation, nodular lesions, liver and peritoneal surface, reticular density increase in the omental area, left ovarian cyst as mentioned before. Then the MRI was a little bit more exact. MRI abdomen pelvis showed bilateral cysts in both the ovarian regions, fallopian tubes bilaterally expanded. Next would be serology and biopsy.
All right, Marcella, what do you think?
Whoa. Let me think for a little bit. So right now I'm thinking more that could be something like neoplastic, and even Shema, that's so brilliant, my friend, she mentioned the pseudomyxoma peritoni, and I remember that I had a patient with that during my rotation on surgery, and I think maybe we could have had some clues. I think maybe with the tap from the ascites, but I'm not sure if that would be like 100%. And also thinking that maybe more into a neoplastic, but I think maybe TB is still something, a possibility, or any other granulomatous disease. And I'm not sure if I'm not sure if sarcoidosis could cause something similar to that, but those are my thoughts right now.
Yeah, I think, Marcelo, if we were to reformulate what we said earlier, I think we were like, okay, there's an assumption. We're making the assumption that there's ovary to peritoneum, but that's because we didn't know any better. We now have learned that the clear formulation of this case is this is a disseminated disease with a predominant manifestation in the left ovary and in the peritoneum. And I think if you look at this, you're really wondering how the symmetry of this process is broken. So if you see metastatic disease and one lesion in the pancreas, you make the assumption that the pancreas is the cause. And so here you see disseminated, there's lymph nodes in the chest, there's peritonitis, and there's only one cyst in the ovary. So the logical conclusion might be that the ovary is the source of all this. But then you're like, wait, ovarian cancer in a young person is virtually unheard of. And the pattern of spread is very, very unusual, meaning that the pulmonary involvement taking the form of lymph nodes before there's pleural effusions or masses would be very uncanny for ovarian cancer. So then you have to do the inverse hypothesis and say that the ovary is not the cause, but it's the target of this disease process. And of course, the possibility of Krukenberg tumor comes to mind. The big flaw in that hypothesis is the vast majority of patients with Krukenberg tumors have bilateral ovarian disease. And especially if the origin is thought to be from pseudotumor peritonei, it's very unusual to involve the left ovary before the right ovary, because the right ovary is right next to the appendix, the most common source of pseudotumor. So there's no cancer that fits this hypothesis elegantly. And then you go back and you remember the geographical exposure for this patient. And this is a classic case, unfortunately, of disseminated tuberculosis. It has a high propensity for the gynecological system, and is a very humble reminder that tumor markers are not really tumor markers. The only tumor markers that are tumor markers are PSA, AFP, and SPEP and serum free light chains. The rest, they don't belong in upfront medicine. They have roles, but they're not tumor markers. So I think I honestly, based on the pattern of the spread, would probably rank TB higher than cancer, which is great news for this patient. But both are probable, and only a pathologist can really tell you the answer, I think. Yeah, what do you think about that, Marcella?
Yeah, I think that was watching your reasoning was important to me to see how much that sense that when I saw so many things, I kind of got a bit lost in my mind, like, oh my God, what is happening? So many things at the same time. And I think that's important to know, like, step back and try to find something that it's key or unique and go from there. So I think that was very a big lesson to me. Thank you. I'm looking forward to know the final diagnosis.
Me too. And I think one thing that you should always hammer home from this case is the time course of symptoms does not equal the time course of disease. This has not been going on for 7 days. The patient only began to notice it 7 days ago. And so you constantly have to know that all the data that you're getting is all potentially not accurate, including the time course here. Very, very important lesson. All right, Hans, tell us more.
Yeah, this was a big learning experience as well. I was shocked. So the next aliquot will be the biopsy and the serology for all kinds of bacterial infections. So Brucella negative. Upon further questioning, the patient denies contact with people who use or who have tuberculosis. Owing to her origin, that was the first thought as well. Maybe she got tuberculosis. So a tuberculin test was done and it was negative. Tuberculosis quantiferon test negative. Acidic fluid microscopy, no biopsy yet. No tuberculosis bacilli, negative acid fast stain. What they did, however, find, and I didn't write it down here, was the adenosine deaminase was tested as well, and it was found to be very high or relatively high. That was the first clue. The next clue that we got was the biopsy of the peritoneum, and it showed nodular opacities, peritoneal surface, granuloma with histiocytic cells, so caseating granuloma. Very suspicious of peritoneal tuberculosis. And the learning experience for me was you don't even have to get contact with people with TB. It is possible that somehow you scratch it into your skin and the microbacterial tuberculosis get into your bloodstream and spread hematogenously without ever touching your lungs. And that gives this rather strange serology result where you can hardly see any tuberculosis. You actually needed the biopsy to prove it. To me, it was a really humbling case because I would have never found out myself.
All right, Hans, as always, you humble us. And I think, Marcella, you brought up TB from the get-go and were so authentic in your thinking because you could easily remain biased by thinking this is TB from the beginning. But when it didn't seem at all like TB, you said it's probably not TB. And then when it became more and more obvious, you brought it back into the fold, which is absolutely amazing. How did it feel to discuss this case?
Oh, it was amazing, really. Not only because it's TV, but thank you so much, Hans. It was such an amazing lesson to me to discuss this case. And I think I learned many important lessons here, but I would say that today, something that I was thinking right now is that when we had that case with Leah, that also had like, we're reminded a little bit here. For some reason, usually I like to rewatch and reflect on that, but for some reason for that case, I was so busy and I didn't do that. And now I was remember a talk by Dr. Dhaliwal where he mentions that how much we need to reflect on our things to be better doctor, not just because you do something every day that you're going to get better. So I think my biggest lesson here is how much we need to reflect on our experiences and our case discussions. So thank you so much.
Yeah, Marcella, I think that's so well said. It's so well said. The power of reflection really cannot be emphasized. And I actually forgot to mention this. I should have, and we'll try to do it on more VMRs. There is, for the next maybe couple of weeks, there is a 50% discount for any IMGs for rlrcpsolvers.com. Some of you may have seen it. We should check it out on Twitter. I say that because that has taught me so much about the power of reflection. So on RLR CP Solvers, we do the case as we just did now, but then we spend a lot of time and put out a case recap or a case reflection and videos from that reflection. I know, Marcella, you've probably seen them before, and I think my growth from just putting those together, as I talked to Maddie about in the car last week, is unbelievable. The power of like sitting on something and reflecting on it. So I think that's probably the most important thing to emphasize is, yeah, this is really, really important, but I hope some of you take a little bit of time afterwards to just sit with your thoughts and reflect on what you learned. Yeah. Hans, I'm really curious now that you've had time to reflect on this case, what did you learn from it?
First of all, because I'm in a country where you never think tuberculosis. So what I've learned, first of all, take a very thorough history. Get to know the patient, the origin, where they come from. Go a little bit into details, and because this one is really very hard to see. The second thing that I learned, here we have a tuberculosis, which is totally atypical from what we've learned at school. We usually get those bacteria through inhalation, then they are in the lungs and they start up in the upper lobes of your lung, and then they might spread whatever way, hematogenously or other, into the rest of the body. But here, the bacteria entered through the skin, and even the tests that we know, like the skin test, well, it's not a very good test, but the quantiferon test should actually be positive. It's still negative. And it's just so mildly, little bit of tuberculosis that you hardly ever believe it. So you had to go for the biopsy, and then you're kind of shocked. So it's reflection, as you said, and it's the complexity of biology as we experience it in our patients is just overwhelming.
I know, that's why that is so well said, and I think it's so true. And that's why medicine is a lifelong journey. It'll never, ever end. And hopefully we'll all stay huddled together on VMR, reflecting and growing on all these cases and their complexity. Thank you, Hans. Leah, I have to apologize. Unfortunately, I'm a little bit late to my shift, so I'm going to duck out, but excited to re-listen to your teaching points when this gets loaded to YouTube. But we'll pass the mic to you. And thank you all. Thank you, Marcella. Thanks, everyone. I'll let you all hang out and finish, but I
Thank you, Rabih.
Bye.
Well, thank you also for the discussion and for the case. I think it was very inspiring to listen to the journey and hear you discuss it and also reflect on it in the end. So to summarize this case, we started with abdominal pain. And then one of the things that was mentioned really early on was how important imaging is in most abdominal pain causes. And there's a mnemonic to help you remember the life-threatening causes of abdominal pain. So think of VIPO, think vascularitis, so any kind of infection, perforation, obstruction, and then ectopic pregnancy, which is always important to consider, especially in a woman with childbearing age, as was this case. And then what was quite particular here is we quite early on found that there was ascites. And so how can we make progress when we have a patient with ascites? The first thing we can think of, or one of the early things is, well, what is the SAC, so the serum albumin ascites gradient? And if it's high, then you can think of causes that are associated with hypertension, so portal hypertension. And then other causes, so the second bucket is when it's low, you think of exudative causes or peritoneal causes. And a transudate so the most common cause is cirrhosis. And it's usually a patient who also has signs of cirrhosis on their skin on a clinical exam. But there are also non-cirrhotic causes, as was mentioned, like schisto. And then I found it was very interesting because I didn't hear much discussion about peritoneal diseases before. So we discussed about how most peritoneal diseases that are over 1 hour, so more than just very acute, are usually hematogenous dissemination. So that's that's their nature. And then with acute, we think of more perforation in the GI tract. And then we have other causes of peritonitis, such as TB, malignancy, or autoimmune disease that have subacute time course. And then the next, so classification of peritonitis is not the time course, but how the localization is. So is it just in one place, so local, or is it really disseminated? And local, we can think of GI, GU, or gynecological causes. And something that was very interesting here is thinking of ascites with the time course of a few days as being usually something of gynecological cause. Then there were quite a few syndromes or tumors that were mentioned. I highlighted some in the teaching points, like the Kupferberg tumor, which is a GI malignancy. Usually it's a gastric cancer that metastasizes. It's like the ovaries and the peritoneum. Typically, it's also bilateral ovarian tumor. And then we have the Meigs syndrome, which is usually associated with a benign fibroma like ovarian cancer with ascites and pleural effusion. And the pseudomyxoma peritonei is also a cause of more gelatinous ascites, and usually also coming from the appendix. So that's why also in the reasoning, Rabih mentioned, well, the right ovary should also be affected because it's closer in localization and the spreading is local. Well, these were all some differentials that were discussed. In the end, we had a positive test of, or elevated levels of ADA, adenosine deaminase, which is an enzyme that is high when T lymphocytes are activated and is very classical for, it can happen in several diseases, but TB would be one of the classical ones. And in this case, in acidic fluid or in pleural effusions that has elevations of these levels, you can always associate that or put TB on your differential when you have that. And I think to finish it up with a more general phrase, time course of the symptoms does not always equal the time course of the disease, which I think is always good to keep in mind. And even though we mentioned some special diseases on the way, I think just the fact that both of you always reconsidered and checked how does my differential fit in with what we know now was very admirable and inspiring to see. And I hope that, or I am sure that all of us watching learned a lot from this case and discussion. So thank you very much and have a great day.
Bye. Thank you. See you all tomorrow.